liquid from inside the bone marrow space, and we're taking a small piece of bone chip so that we can look under the microscope and we can see what is there, what is not there, what is, it's bad enough to hear yourself once, it really hurts when you have to hear it twice. What do they look like? And then based on the bone marrow, we do a lot of very specific testing. So we can sometimes have a suspicion for MDS very quickly based on what the cells look like. We call that morphology. So MDS has like very defining characteristics. But the subtype also depends on additional information, including evaluation of the bone marrow chromosomes and evaluation of a select gene panel so that we can subclassify MDS. And so the classification has become very complicated, and it often does take a couple of weeks in order for us to get all of this information together so that we can dot our I's, cross our T's, and really put all of the pieces together. So why is this important? So this is important because MDS is very heterogeneous. And if you go online, MDS can affect people very differently and quite drastically. And there's a lot of different subtypes. And so we need all of this information so that we can put it together to try and figure out what type of MDS you have so that we can figure out how it's going to affect you and come up with an optimized care plan to try and do what we can to keep things stable for as long as possible. So some people can have very low-risk disease. Low-risk disease tends to mean that the blood counts are mildly affected. It tends to mean that most of the chromosomes are normal, and it tends to be impacted by the types of gene mutations that are present in the bone marrow. It's very common to have gene mutations, but the combination of gene mutations ultimately is important in estimating somebody's risk. Other patients, on the other hand, can present with more acute illness, often with lower blood counts. Sometimes they're transfusion dependent, and often the bone marrow has characteristics that make us think that this is more closely approximating something like leukemia. And so that makes a very big difference because our management of lower risk MDS is not at all the same as our management of higher risk MDS, and so that's why we have to take an individualized approach to each individual case. So to formally estimate, it's a little bit nerdy. So we used to primarily look at people's blood counts and their chromosomes, and now we have something called the IPSS-M, M for molecular risk stratification. So actually for every new consult and for all repeat bone marrows, we go online. There's like an online calculator or an app that you can download. You don't put in anybody's like personal information, just some characteristics. So you input things like age, blood count, so like hemoglobin, neutrophil count, platelet count. We put in information about the bone marrow blasts, and we put information about the chromosome abnormalities as well as gene panel results. And essentially, so here on the right-hand side, you can see that this fake person, that is none of you, has bone marrow blasts of 3%, a hemoglobin of 97, platelets of 130, a neutrophil count of 1.9. They are 72 years old with normal cytogenetics, and they do not appear to have any gene mutations. So this spits out an IPSS-M score. It also gives us an old score and an age-adjusted score, which computes average estimates on a population. So it's a good starting point for a conversation, but it is not the entire conversation because, as we all know, no one person can really follow this population estimate. And so if the median, in this case, if the overall survival is estimated at 6 years, that means some people will live for longer, some people will not live for 6 years, and so there's a lot of individual variation, but it can kind of provide a bit of a framework that we sometimes use in terms of trying to decide our starting point. So this is called the IPSS-M risk stratification system, and it's something that we have been implementing fairly routinely over the past 2 to 3 years with some of our novel genetic testing. So when we move on from making the diagnosis, estimating the risk, the next question is, what are we going to do about it and how are we going to treat the MDS? And the reason why I went through that complicated calculator is primarily because how we treat MDS is entirely dependent on the disease risk. And so in the context of lower risk disease, our objectives are very different than what our goals are for higher risk MDS. So in lower risk MDS, the goals are to improve symptoms if people are currently symptomatic and to try and maintain quality of life for as long as possible. In higher risk MDS, where the disease is evolving a little bit quicker, or where the risk of complications is higher, then primarily the treatment objectives are to improve survival. So we know that by treating people with chemotherapy or transplant in this setting, we can improve survival. Of course, we also want to try and maintain quality of life and improve symptoms, but the objectives are different. So here's a list of MDS treatments, and really they vary depending on the MDS risk, but also based on the MDS subtype. So in some people with a diagnosis of MDS, the blood work might not be entirely normal, but it might be mildly impacted, in which case it's entirely appropriate to observe. For some other subtypes, we use things like lenalidomide or luspatercept. We'll talk a little bit about that. And then as the MDS risk increases, we start looking towards things like hypomethylating agents like azacitidine or Inqovi, or allogeneic stem cell transplantation. So I thought we would go through just some of the more common treatment options that we have for lower risk MDS. I also think it's important to clarify intervention in low risk MDS does not modify disease evolution. So when I say that we are not focused on improving survival, we would love to improve survival for all patients, but in trials, the trials show that in MDS, you can improve how people feel, you can prevent complications, but administering therapy or not administering therapy does not impact how long people live. And so that's why we have a little bit more leniency in terms of making sure that we're coming up with an individualized plan that's tailored towards people, how they're feeling, what complications they might be experiencing, okay? So really for MDS of all subtypes, red blood cell transfusions are kind of the backbone. Often we're trying to prevent the need for blood transfusions in the first place, but in the setting where we're unable to do so, this is really the mainstay of therapy. So red blood cell transfusions, I kind of think of it as like the equivalent of dialysis in kidney patients. So when your bone marrow is unable to make blood cells effectively, eventually what happens is that the tank becomes emptier and emptier. So if a normal hemoglobin level is somewhere in the realm of 120 to 130 or so, slowly what can happen is that the hemoglobin can drift down and it gets to the point where we need a top up. You can only operate with half a tank of gas for so long, and then eventually it becomes dangerous. And so in the hematology and in the context of MDS and in the context of impaired bone marrow function, red blood cell transfusions are really our mainstay of therapy. So how do we do a transfusion and why do we do a transfusion? So there's different ways to do blood transfusions. In MDS clinic, ideally we try and do them a little bit more proactively, meaning that we're not doing them in an emergency setting or in the emergency department at all. And so we tend to serially monitor people over time so that we can try and catch a lower blood count before it becomes critical. Okay, and so what we commonly do is we might do blood work once a week, once every 2 weeks, once a month, less common kind of depending on the trajectory on a very individualized basis. And then once the hemoglobin drifts down into transfusion territory, then there's a bit of an ongoing conversation about when and how we're going to do blood transfusions. So, for example, a pretty typical starting point for transfusions might be a hemoglobin of 80, but that is impacted by how quickly the hemoglobin's going down. If it goes down quickly, then people tend to be more symptomatic than if it's going down slower. It's impacted by people's age. So the older you are in general, the more symptomatic you are when the numbers get lower. It's impacted also just by people's sense of well-being at individual numbers. No two people are alike. Some people might have a hemoglobin of 90 and feel amazing. Some people might have a hemoglobin of 90 and feel like they're really dragging. And the same can be true at a hemoglobin of 70. And so our enthusiasm to provide a blood transfusion really depends on if somebody is experiencing symptoms, and also how they feel after a transfusion. Okay, so some people Let's say the hemoglobin is going down, they get to a hemoglobin of 80, we give them a transfusion and they say, oh yeah, I was exhausted when I got here. I could barely do a flight of stairs and I danced out of the cancer center. Those people are probably like more excited to come back for another transfusion when they hit a threshold of 80. Other patients tell me, oh yeah, I felt tired and I still felt tired the next day. Those people are probably like not super enthusiastic to come and spend 4 hours with us on a Saturday. So there really is an individualized kind of plan here. And so at a minimum, we do it to be safe. And we also do it to make people feel better, particularly in instances when those people notice a big difference in terms of their symptoms. For each blood transfusion, it takes 2 hours and raises the hemoglobin by about 10. So if you're coming in and your hemoglobin is 70 and we give you 1 bag of blood, 2 hours later your hemoglobin should be about 80. If you get 2 bags of blood, which is kind of the most that we ever would give at one individual time, then your hemoglobin is increasing to 90. And so there's trade-offs between giving 1 unit versus 2 units. On one hand, if you give 2 units, you might require blood less frequently. But the downside to getting 2 units is it means that you're sitting there for 4 hours, and that's sometimes a big ask. So there's no one way to do this, but these are some of the considerations that we take into mind when we're coming up with a plan for an individual person. So we talked a lot about blood transfusions, and now we're going to talk about all of the different things we can do to prevent people from needing them. So one of our initial kind of go-tos in the context of low-risk MDS is a medication called erythropoietin-stimulating agents. So this is a medication that is commonly given in the context of chronic kidney disease to help people make blood cells to prevent low blood counts in the context of kidney impairment. We also can use higher doses in the context of MDS, and essentially what it is it's a weekly injection that patients can give themselves that stimulate the bone marrow to make more blood cells. So your bone marrow relies on messaging from your body to tell it to make more blood cells and to tell it kind of with what enthusiasm it should make blood cells. And essentially all we're doing in this setting is we're kind of just flogging the system a little bit, and we're saying, no, I know you're trying, but you need to try harder. And so that's really what this medication is doing. This medication is very effective in people early on when the hemoglobin is first starting to drift down. It also is effective in people with lower risk MDS, and it tends to be effective if your baseline erythropoietin level, which is a marker of the signaling to the bone marrow, is on the lower side. So if your baseline level is under 200, then supplementing with more erythropoietin can be very helpful. Sometimes that signaling is already really ramped up, and so adding more doesn't really make a difference. So if your level is much higher than 200, and definitely if it's over 500, this isn't something that we would typically start because the likelihood of it making a big difference is lower. The next common-ish medication that we use in MDS is a pill called lenalidomide. So lenalidomide is a chemotherapy pill. It actually is primarily used in a completely different type of blood cancer called multiple myeloma. But there were trials that were done a while back that showed that this pill can be very helpful in a specific subset of MDS. So when we do the bone marrow and we look at the chromosomes, a common pattern that we see is that there's a deletion on part of chromosome 5. It's called deletion 5q. And in people who have MDS with deletion 5q, giving a very low dose of this lenalidomide can, for whatever reason, help the bone marrow improve its blood production. So amongst people with lower risk MDS who have deletion 5q abnormality, this would be our initial go-to therapy to improve the hemoglobin. And this medication can be wonderful. It's quite well tolerated. It has very little in the way of side effects, and the durations of response can be quite long. So if people are responding, they can often respond for many years. Luspatercept, another long word that starts with L. So this is a subcutaneous injection. This is also something that we have in our arsenal for lower risk MDS. And this medication is primarily used in a lower risk MDS subtype called MDS with SF3B1 mutations. So SF3B1 is a mutation that is part of our gene panel that we do on all of our diagnostic bone marrows. And it is a fairly common subtype of MDS. And there were clinical trials. There was the Medalist clinical trial and the Commands trial, and they were looking at luspatercept in people with lower risk MDS who had SF3B1 mutations, and they found that amongst this patient population, their response rates were actually quite high. Okay, so we would typically use this medication in lower risk MDS when people have tried EPREX and it didn't work, or when they're not likely to respond to EPREX, perhaps because the baseline EPO level is high, when they have this mutation. The benefit of this over a blood transfusion is that when it works, you're really going for an injection. You're not standing there for the 2 to 4 hours for the transfusion, and then you are exposed to less blood products. So we often will give that a try when we're able to. So that is really kind of in general, our treatment approach for lower risk MDS, okay? Lower risk MDS is distinctly different from higher risk MDS, but lower risk MDS can become higher risk MDS. It doesn't always, but it sometimes can. And when we're dealing with higher risk MDS, our options are primarily limited to chemotherapy or bone marrow transplantation, okay? So azacitidine is an older medication. I actually haven't started anybody with MDS on this medication in a very long time, but it used to be the mainstay of therapy for higher risk MDS. This medication can work relatively well, but it's very annoying to give. So it is an injection that's given into your stomach. It's given once a day for 7 days, every 28 days. And unfortunately for this treatment, it's not something that can be given at home. And so it's a bit less ideal because it does require that people come to the cancer center for those 7 days each month. So it's just very time intensive and cumbersome for people to come to a cancer center in order to get this medication. This medication works by improving the functioning of the bone marrow by altering the methylation pattern of the DNA. And there's a little bit of hand waving because I don't think anybody totally really knows why it works, but that's what we're supposed to say. So, but it does work, and it is kind of the backbone of therapy for people who have MDS, and we use this medication very commonly in AML as well. The benefits of this medication are that if we can get people through the initial few months of therapy, the goals are to try and improve the functioning of the bone marrow, which hopefully means that the blood counts are improved and hopefully means the patients have been able to get off of blood transfusions. The downsides of this medication are that we tend to make things a little bit worse before we make things better. So when we're starting this medication, often the bone marrow isn't functioning on all cylinders. We're layering on some chemotherapy, and so the blood counts do tend to go down. So we have to watch very closely, often with blood work once a week or closely in that kind of ballpark, so that if people need increased support for the bone marrow when the bone marrow isn't functioning well, we're able to help provide that support with blood transfusions. Inqovi is kind of like azacitidine's cuter cousin. So Inqovi is a pill. And so it's very attractive primarily for that reason. So this is a newer medication. It has been available in Canada routinely since January 2023. We used it prior to that on an access program available through the drug company. And this medication is appealing because rather than receiving those subcutaneous injections, you can just take a pill at home. And so it really does minimize the number of trips people have to take to the cancer center to get that injection. It's also a hypomethylating agent, so it's a very similar class to azacitidine. Currently, it's only available in MDS. There's ongoing trials looking at transferring this availability to acute leukemia, but I would say this is the most common medication that I start up front in people who have MDS. It has similar problems to Inqovi to azacitidine, in that when we start the medication, the blood counts tend to drop. And especially if we administer the medication as it was studied in the clinical trials, the blood counts drop a lot. And so I actually do not commonly start with full dose. Full dose of this therapy is 1 pill once a day for 5 days, given once a month. So you get 5 days on of therapy and 23 days off of therapy. And that doesn't sound like a lot, but your bone marrow would suggest otherwise. So I usually would say I start somewhere in the realm of 3 to 5 days up front for people who are starting this therapy. And if it goes well, then you can always increase. But I actually personally don't think that there's a big difference between 3 or 5 days, other than it helps to prevent toxicity. Similarly to azacitidine, when we start this medication, we have to watch the blood counts very closely. People are often reliant on blood transfusions. We expect that. And if we can get people through the first few months of therapy, then hopefully what we expect to see is that the blood counts are improving, people are coming off of their blood transfusions, and then we continue it thereafter as a bit of a maintenance strategy. So that is the ultimate goal. It works in probably 50 to 60% of people. So it's not a guarantee, but when it does work, it can be quite helpful. And then lastly, we have bone marrow transplantation. So bone marrow transplantation is the only therapy that we have that will get rid of MDS for good. So there are pros and there are cons with this. So the benefit is that if you go through a bone marrow transplant and if it's successful, you no longer have MDS anymore. And so that's the rationale for why we do it in the first place. The downsides with bone marrow transplantation are that it's a big production, it's quite risky, and it can be quite toxic. So it does require that people are admitted to hospital, often for a month or more. We give very aggressive chemotherapy to try and clean out the bone marrow space. With that comes risks because your bone marrow is completely empty, and so you're vulnerable to complications like bleeding and infection and toxicity from the chemotherapy. And then we monitor people very closely thereafter for the first few months as their new bone marrow is starting to take effect. And it can work very well, but it is really limited to people who are able to handle that toxicity. So anytime you're doing something, you have to weigh the potential benefits with the potential harms. And so the potential risks of a bone marrow transplant increase quite a bit as we get older. And eventually it gets to the point where doing the transplant is more toxic than not doing the transplant. And so it's really probably an option in only a subset of people with higher risk MDS. I think some people who have had a bone marrow transplant are on the patient panel, and we'll likely talk to you a little bit about that today. So that is kind of our current arsenal for therapies for MDS. Really, again, it hinges very much so on what the MDS subtype is, and then also the MDS risk. But I thought I would take a couple of slides to talk about some of the initiatives that we have ongoing as we look to move these therapeutic targets forward. So this is like a very complex look at a cell, and everything here in a box is looking at novel drug targets that either have been studied or are being studied in MDS, whether that's in the lower risk or higher risk setting. And I include this primarily because there's a lot of interest to try and improve our therapies in MDS. This is the exact same thing, but in a slightly more boring table. So the COMMANDS trial. So the COMMANDS trial is looking at increasing access to luspatercept in lower risk MDS. So we talked a little bit about luspatercept. We talked a little bit about how luspatercept is a subcutaneous injection. It's given every 3 weeks. It's used in lower risk MDS, and it can be particularly helpful in people who have a specific subtype of MDS, like particularly the MDS with an SF3B1 mutation. The COMMANDS trial builds on the MEDALIST trial, which was done a few years prior to that, in that it's looking at accessing luspatercept in the frontline setting. So prior to the COMMANDS trial, we would always use EPREX. If EPREX either was unavailable or didn't work, then we would move on to luspatercept. In the COMMANDS trial, it was comparing EPREX to luspatercept in the frontline setting, and it showed that particularly in people with an SF3B1 mutation, this can offer a very significant improvement in bone marrow functioning. So based on the COMMANDS trial, funding across Canada is underway and is something that we will likely be able to implement in Manitoba very soon. The IMerge trial was also another trial that was recently completed. This is a medication called imetelstat, and it's a telomerase inhibitor, and it is a medication that is working its way into some treatment algorithms, again, for lower risk MDS. And it was studied in a patient population of lower risk MDS, particularly when they either did not respond or were ineligible for ESAs or EPREX. It's an IV infusion, it's once every 4 weeks, and they were able to demonstrate that about 40% of people were able to achieve transfusion independence. And transfusion independence is often the primary goal of a lot of these therapies in the lower risk MDS setting. The problem with imetelstat is that it does decrease bone marrow functioning a little bit more compared to luspatercept. And the patient population of the COMMANDS trial and the IMerge trial are largely overlapping. And so in real world, now that we're using these trial results, if most people were to have a preference over luspatercept or imetelstat, most people would prefer to use luspatercept. It's just a little bit easier to give. It's a little bit easier for patients to tolerate. And so I think the COMMANDS trial likely will have a bigger impact on Canadian MDS management than imetelstat, but it is still good to have another tool in our toolkit. And then in Canada, so historically, a lot of the MDS research came from Europe. So Europe has been a very productive contributor to novel therapies. France, Italy, in particular, have done some really wonderful trials that have advanced how we care for people with MDS. But over the past few years, and perhaps even a little bit longer in some instances, Canada has really tried to get their act together to get organized so that we can contribute as well. And so we have 3 kind of fundamental research initiatives that are available across the country. And I thought we would go through each one of these in a little bit of detail. So right now we have the Canadian MDS registry. This has been active since 2006. So we have about 3,000 MDS patients that we've been following since 2006. And really the vision at the time when this was started was to develop a comprehensive Canadian registry of people with MDS or CMML, which is a bit of a related condition. And why would we do this? This was started because often centers have like center-specific databases, but it's hard to know how that compares to other centers. And often you kind of get used to what you know, and it's important to challenge yourself relative to other centers as well. And so by doing this, we are essentially able to create a very large Canada-wide database so that we could evaluate a pretty rare condition. A lot of the questions that we want to ask require more patients, and they require evaluation beyond a single center, and so this registry does enable us to do that. And it also enables us to learn from the patients that we see in clinic. So we can learn things about like what is the best sequence of therapies? Is it best to give EPREX and then luspatercept and then imetelstat? Or is it better to give EPREX and then luspatercept and never imetelstat? Or should luspatercept come before EPREX? The trials can ask that question, but sometimes how you translate something from a clinical trial to the real world is not the same. And so making sure that you still ask these questions and the people that you're seeing in clinic is a very important safety and safety kind of strategy. The other kind of benefits of these is that we can evaluate the impact of novel therapies as we implement them, and then we can also evaluate new lab technologies and how that impacts clinical decision making. One example of this was like the impact of myeloid NGS testing. So we never even looked at genes, we never even considered them in our treatment plan. And now that we routinely do NGS testing and now that we routinely evaluate people according to the IPSSM risk stratification, we can go back and we can see how does implementation of this lab strategy modify how we're caring for people with MDS. The other reason why registries are important is that even though it shouldn't be the case, practice varies from one province to the other. And I don't mean like drastically varies. Like in general, most people should have access to similar therapies. But how therapies are used, there's a lot of art to therapy administration that is beyond what's done in a textbook. And so, for example, small questions like when we implemented in COVID, should you really start with 5 days? Should you start with 4 days? Should you start with 3 days? Should you do blood work once a week? Should you give antibiotic prophylaxis? Should you give antiviral prophylaxis? What type of nausea medication is the best? Should they use metoclopramide? Should they use a Dandratron? There's a lot of very small kind of supportive care nuances that can vary from center to center just based on historical practice patterns and people's experience. And so by creating a registry, then we can answer some of these questions as well. Also, Canada is very different than the US in lots of reasons. And so evaluating how MDS presents in Canada, evaluating our access to therapies, our sequencing of therapies, and how people do in Canada relative to the US is a very important distinction to make. So essentially, we are still enrolling. We are enrolling people with newly diagnosed MDS and CMML, and it's probably a little bit more than 15 centers across Canada, but I would say on average we enroll about 250 patients per year. That's our goal. The next research strategy that I wanted to talk about is something called MyeloCan. It sounds similar to the third one I'm going to talk about, which is called MyeloMatch, but they're not the same. So MyeloCan is actually a Canadian platform trial that started this year. And it was created so that we could essentially create the space to study patients who have MDS and AML efficiently. So the problem with clinical trials is that we rely on them. We're heavily dependent on clinical trials to get access to novel therapies. We're heavily dependent on clinical trials to learn about what works relative to what we're currently doing. But the trial designs are very inefficient. They cost millions of dollars. They take years or sometimes even decades to complete. They're very segregated. Our methods for trial participation are very separate from how we deliver care in clinic. And so there's a lot of inefficiencies that really delay knowledge generation. And so the goal here of MyeloCan was to try and bridge that gap a little bit. And by kind of focusing on what Canada does well. Canada probably doesn't have the volume to come up with phase 1 drug studies and to implement that across Canada in and of itself. But Canada does have the volume and the enthusiasm and the motivation and the commitment to ask very important questions that can materially modify how we manage patients with MDS. And Canada, as an academic community, has agreed to try and incorporate research into clinics, which I think is a really important step. So what we are trying to do is we're trying to design very efficient and pragmatic trials that allow us to learn from the people that we see in clinic without creating such a production, if that makes sense. So the patient population for this platform is patients who have MDS or acute leukemia. It was really the inception of this research program really came about because it is rare, and if you don't have an organized approach, it's easy to miss people. And it's a hard patient population to study because sometimes people are older, they're frail, they're busy, they're transfusion dependent, they're coming to clinic often, they're geographically distributed, they often don't live in Winnipeg or in Toronto, and they're unwell. Sometimes they're in hospitals, sometimes they're not. And so we really need to meet people where we are so that we can do what we can to advance the therapies that they have available to them. So MyeloCan is working with patients. It's designed with and by patients. We're looking at ways that we can prove how we consent people for research rather than providing them a 20-page case report form. We're looking at novel methods of consent. We're looking at trying to capture and use data electronically when we can so that we're not doing everything manually in clinic. We're testing a platform trial. The platform trial is kind of a fancy way of saying there's a lot of startup that gets involved in building a clinical trial. And so typically, historically, you have to build a new house every time you start a trial. If you have a platform trial, you can build a house and then you can renovate onto the back. So that way, if you have the existing infrastructure, if there's additional questions that you want to ask, you don't have to start at the beginning. So it really decreases time from question to implementation to increase efficiency. And we've built a really committed network of incredible people across Canada here, which is very exciting. So this is the design of the MyeloCan platform. It's very broad and is essentially built to allow the the enrollment of anybody with MDS or AML, currently in the adult setting. And really what we've started with is we've started with 2 trials, and both of them are primarily looking at supportive care. So the first trial we're looking at is a trial of tranexamic acid, and the second trial that we're doing is a trial of antimicrobial prophylaxis. So in the TXA trial, this was officially open, it's now open at 6 centers, and essentially what we are doing is we are evaluating ways that we can support people who are at risk for bleeding. So people who have MDS or leukemia, who are receiving less intensive chemotherapy, like Inqovi or azacitidine, for example, who have a very low platelet count, a platelet count of under 30, are at risk for bleeding. And routinely, we monitor the blood counts. Sometimes we give platelet transfusions to try and mitigate this, but platelet transfusions are very time intensive and platelets don't last for very long, so it takes a lot of time for people to come for the platelets. And so this trial is asking is, can we use a medication twice a day to see if we can prevent bleeding? And so essentially 50% of people get the medication, 50% of people do not get the medication, and then at the end of the day we'll compare patients' experience, their quality of life, and their bleeding amongst the 2 groups to see if this medication is a helpful strategy to prevent that complication. The other question that we're asking, and this is, again, very basic foundational questions, but questions that drug companies would never ask because there's no money in answering these questions, is that in a very similar patient population, so in people with MDS and AML who are receiving chemotherapy, we know that the white blood cell count goes down. So our concern when the white blood cell count goes down is that people could theoretically be at increased risk for infection. What we don't know, and what has never been studied, is does giving an antibiotic routinely prevent their risk of infection? And so we're doing the exact same thing. We're giving half the people an antibiotic, we're giving half the population no antibiotic, and then we are going to compare how people feel, whether they got infections, and their quality of life at the end of the trial to see if does giving this antibiotic help people. And if it doesn't, that's also good to know because it's one less pill that you have to take each day. And then the last research initiative that I wanted to talk about is the MyeloMatch trial. So not MyeloCan, but MyeloMatch, but pathologically similar. So this is a cool trial. It's a collaborative effort that is being implemented across Canada and also the US. This is actually more so looking at precision medicine in myeloid cancer. So myeloid cancer, for this purpose, means MDS and AML. And so this trial is aimed at evaluating people at a genetic level using like the IPSS-M score and some of the gene mutations that we talked about, and then trying to target people and provide them with medications that target the gene mutations that they have. So in this particular trial at the moment, there's a number of molecular mutations that have an actionable medication available. So if you have an IDH1 mutation, we have ivositinib, IDH2, we have enasidenib, FLT3, we have a number of medications available, KMT2A, we have revumenib, we use that for NPM1 as well. But essentially, there's a very complicated trial design here, but we have the MyeloMatch platform active in Manitoba, and across Canada, we are trying to open individual targeted trials so that when people are diagnosed, if they have a gene mutation, we can provide them with a therapy that is specific to the type of mutation that we have. And anytime you have a rare disease and then you have a rare mutation, you need a lot of organization in order to get enough people, and so that's why this is an effort that Canada participates in, but it's also something that is occurring in the US as well. So we're very excited. This idea kind of came about in 2015, and it took almost 10 years to get up off the ground, but it is now up and active and only mildly impacted by the US government. So we've got a lot of active research here in Manitoba, across Canada, and in North America, whether that's registry, whether it's supportive care platform trials, or precision medicine targeted trials. And really, that is all that I had scheduled for today. So we have lots of enthusiasm to improve how we deliver care for people. And while we're making headway, there's definitely room for improvements. And with that, I'm happy to take any questions.
Thank you, Dr. Houston. If anyone has a question, I'll bring the microphone to you just so the people online can hear your question. So does anybody have one right now?
That's okay. It's not a quiz.
I'm just going to bring you the microphone.
Thanks. I was trying to remember all the therapies, and you had mentioned that, and I won't remember which one it was, but you were saying that younger populations had better responses to one of the therapies, and I was just wondering what tends to be that age cutoff, and hopefully you remember which one that is that I'm talking
Bone marrow
about.
transplant?
Is there another therapy that involves?
So the only therapy that I talked about that primarily has a age cutoff is a bone marrow transplant. And even that is a little bit soft because we're more than a number, right? And two people who are 65 are often not the same. Two people who are 75 are not the same. And so historically for bone marrow transplant, the cutoff was 60, which is quite young. But that was like 10, 15, 20 years ago when the therapies for bone marrow transplant were very, very toxic. So over the years, we've been able to decrease the toxicity profile of the chemotherapy that we use to do bone marrow transplant, and so we've been able to increase the age and transplant more complicated real life people. So in Manitoba, I have transplanted people up to age 73 or so. Again, there's no magic number, and if somebody was 74 and they were otherwise a very good candidate and they were aware of the risks and they really wanted to proceed, then that's a kind of a conversation that we would have. But things that we take into consideration for transplant eligibility, you need to make sure that the disease risk justifies the toxicity. So in no patient, other than very, very few exceptions, is low-risk MDS a good idea to transplant, because you can do quite well with low-risk MDS, and so you don't want to accept unnecessary toxicity if it's not needed. So the disease has to justify the risk. The patient has to be functionally well enough to withstand the treatment that is going to be administered. And so part of that is age, and part of that is just general well-being. So if people have had multiple comorbidities, if they've been in and out of hospital, if they're primarily bed-bound, then those aren't a group of people that are going to be able to get out of a transplant and do well and be expected to thrive. And so in that setting, it would be safer not to do the transplant. And then people also have to be just crazy enough to want to do it, because it's not something that you would voluntarily sign up for if you didn't need it. And it's a commitment, and it's a lot of days in hospital, and you don't feel well for a long time. And so for some people, that is just not something that they're interested in. And so in as many people who accept transplant, I also have people who decline transplant, and that is 100% valid. So there's not one way to slice that. But I would say of the therapies we talked about, transplant was really the only one that we have to be very careful, just because the toxicity profile is so high.
Other questions?
Morning.
Hello, good morning.
Hi. I was on the Spatacept, as you know. Do you know if they're doing any research with that medication so that it can kind of be ramped up and improved? Like, I don't know why, for myself, it stopped working, but it did. But do you know if they're doing research to try to improve on its effectiveness?
They are. So there's always novel. So luspatercept was designed with a certain mechanism of action in mind. So it's a SMAD3 inhibitor, whatever that means. It helps with bone marrow maturation. So now that they've identified a target that is effective in MDS, there's always new drug companies that are looking to improve the next luspatercept. And that is both helpful for us because it means we have other options available, and helpful for drug companies because it means they can market something that's novel and make money off of it. But so those are always in the works. But even with luspatercept, this is a medication that really has only been available for a few years. And so there's always like a little bit of learning curve and optimization that needs to happen before we can truly figure out who the best candidates are, what the best way is to administer the medication, how to dose modify, and how to sequence it. And so there are trials, for example, looking at like luspatercept in combination with other things in the first line. So maybe like luspatercept and Eprex versus just one or the other, for example. Through MyeloMatch, there's a trial using luspatercept in combination with a novel therapy in people in the frontline setting. So the bottom line is yes, and I think luspatercept was a good starting point, but I think we're really only at the beginning of our journey in terms of figuring out how to best use that medication for people.
Anyone else? I'll just check if there's any questions online.
Yep.
Okay, we do have one question online. Does MDS develop slowly and then become more serious with age?
So sometimes. I wouldn't say that MDS becomes more serious with age. I would say MDS tends to occur as we get older. So the average age that it occurs in is about 70. So 50% of people are under 70, 50% of people are over 70. And how MDS changes varies a lot from person to person. So some people are diagnosed with low-risk MDS and it can be quite indolent, which means that it's mild and it doesn't change quickly, and it's something that we monitor for years, and sometimes it's nothing that we even have to do anything about. So that's one end of the spectrum. Some people right off the get-go have a higher risk disease. Just biologically, they're very different. And so those people justify either a bone marrow transplant or chemotherapy at the beginning, and there's no period of observation in that setting. And those two are probably never biologically the same. It probably means that in the bone marrow, where you have a lot of blood cells that are dividing, sometimes what can happen is that the cells make a mistake. And then instead of making healthy blood cells that follow the rules, and that behave and function normally, you're making cells that are a little bit abnormal. And so they either don't follow the rules, they take up too much space, or they get chewed up by the body because their quality control is not as good as what we would typically expect them to be. And in that process, the mistakes can be different. So, and that would kind of translate into either different gene mutations or different chromosome abnormalities at the end of the day. The reason why I said possibly for that question is that sometimes lower risk MDS can become higher risk MDS, but the opposite is not true. Higher risk MDS never becomes lower risk MDS. And so sometimes what we see in lower risk MDS is that the blood counts can change slowly. And you know, we might try a couple of therapies for low risk MDS, but what can happen in a subset of people, and not everybody, but some people, is that the low risk MDS can become high risk MDS. And then we start having that conversation about the chemotherapy or the bone marrow transplant. So things can evolve a little bit over time from one person to the next.
Two questions. Is MDS hereditary, and would it be a factor in resulting infection of other cancers that are more known?
Yeah, that's a great question. So the most commonly known risk factors for MDS are previous chemotherapy exposure and radiation exposure. And I don't mean like you use a microwave for your food. I mean like you had radiation to your prostate for prostate cancer. And so in that setting, we call it therapy-related MDS, and that occurs because the chemotherapy that is given for breast cancer or colon cancer or prostate cancer is given to kill those cancer cells, but it can also do damage to the bone marrow. And so when it does damage to the bone marrow, sometimes that results in MDS. So those are the most commonly known risk factors. Inherited predisposition to MDS exists, but is by far the minority. So 80% of MDS happens for no reason, and most of the time it is not something that is passed from family to family. Okay, so We're working actually right now on Canadian guidelines for inherited predisposition testing for people who have MDS and acute leukemia, and it'll hopefully be available next year. But there are certain flags that we use to prompt that extra level of testing. So if there's people who are particularly young, so if you're younger with MDS, then that's a bit of a flag because that's unusual, it's uncommon. If you have particular genetic mutations, sometimes that can kind of flag us that this isn't something that would normally be acquired. Sometimes this is something that people are more often born with. Or if it's something that has happened in multiple family members. So occasionally, again, not very commonly, but occasionally we have people say like, oh, well, my sister had MDS and my dad had leukemia, and that's just like too much of a rare thing in one family to really be something that you would expect, and that warrants another level of testing. So if that is something that we suspect, then usually what we do is we take a biopsy of somebody's skin, which sounds weird, but it's called skin fibroblast testing. And the reason why we do that is that the skin is obviously very distinct from the bone marrow. So we know what the bone marrow profile looks like. Then we look at the skin profile. And if the bone marrow shows damage but the skin does not, that suggests that the damage was acquired in the bone marrow. It developed in the bone marrow, but it wasn't likely something that you were born with. Whereas, if we do testing in the skin and we see that you have the same mutation in your skin that you have in your bone marrow, then that's probably something that you were born with and just something that has evolved over time. So there are ways for us to distinguish that, and that is testing that we do sometimes. It's testing that we're doing more and more often. But it's not a commonly inherited condition, and it isn't something that tends to be passed from family member to family member most of the time.
Okay, we're just going to go to another question online. Can you comment on the relationship to myeloproliferative neoplasm?
Yeah, so myelodysplastic syndrome and myeloproliferative neoplasm sound similar and are not at all the same. So myelodysplastic syndrome, so the common parts mean that they involve the myeloid compartment of your bone marrow. Your bone marrow is your blood factory, and in your blood factory there's two pieces. There's myeloid, which is like neutrophils, hemoglobin, platelets, and then there's lymphoid, which are lymphocytes of varying different types that primarily function in your immune system. So the myeloid is the part that I treat, that Lynn will talk to you a little bit about some of the other stuff, but myeloid is kind of the world where I exist in, and so myelodysplastic syndrome and myeloproliferative neoplasm overlap in that they involve the same types of blood cells, but they're completely distinct bone marrow conditions. So in myeloproliferative neoplasm, the proliferative means that things are too high. So that might mean that the white count is too high, the hemoglobin's too high, the platelets are too high. And they're caused by a very classic set of mutations that trigger that to be the case, whether that's a JAK2 mutation or a CALR mutation or whatnot. In myelodysplastic syndrome, it means that the cells look a little bit funny, that's dysplastic, and it's a too low problem. So you don't develop, people with myeloproliferative neoplasms don't develop MDS, and people with MDS don't develop myeloproliferative neoplasms. They tend to be mutually exclusive. They just sound very similar.
Is there another question here?
Is there a way to avoid or prevent for having that kind of disease?
No. So unfortunately, it's not something that people get by bad choices. So you don't develop MDS because you did X, Y, or Z wrong. When people have MDS, what I usually tell them is that within our realm of control is what we eat and how active we are. So we routinely do tests just to make sure that there's no nutritional deficiencies that are contributing, but having a balanced diet can be very helpful, and being active can help you both remain more functional and better withstand the treatment that we're doing as we go through our MDS journey. But there is nothing that one person does that causes MDS. Sometimes people are unlucky enough to have breast cancer and then develop MDS after, but again, that's not the person's fault. It's the treatment that was required for the breast cancer had a very unfortunate unintended consequence.
Okay, we have one more question online before we take a break. Kayla says, when you said that MDS is rare, what percentages are we talking about? also, what percentages of the MDS are gene mutation caused versus no known mutation?
Oh my goodness, you guys are speaking to my nerdy heart, and I love it. So there are about 50 to 100 cases of MDS each year. And some of those are lower risk MDS and some of those are higher risk MDS. 50% of MDS has a chromosome problem, so we call that a cytogenetic abnormality, whether that's monosomy 7 or deletion 5q or a combination thereof. And 90% of MDS will have a gene mutation. So there is a very, very small subset of people who can have MDS without a chromosome problem or a gene mutation, but that's 10% or less. And in that group of people, you always want to think, like, is this actually MDS or are we missing something else? Because sometimes in that setting, you're making the diagnosis based on what the cells look like. And there's a lot of things that can make cells look funny in the bone marrow. So for example, like if you're in the ICU, if you're septic, if you're on a ventilator, if you have an infection, if you have a nutritional deficiency, cells can look abnormal in the bone marrow. And so if you don't have evidence of a chromosome abnormality or a gene mutation, you just want to make sure you're not missing something else, because you would be then compelled to treat that, if that makes sense. So 90% is that answer.
Oh, we have one more question we'll take.
Okay.
So since you were talking about acute illnesses that cause bone marrow abnormalities, the underlying piece being that the bone marrow eventually figures things out and says, okay, no, this is how we figure it out. Mm-hmm. Whereas in MDS, that never happens, essentially, correct?
Yeah, so for example, like sometimes we get consulted because somebody in the ICU has low blood counts. And when your body is sick with something, whether that's an infection, the infection can affect many organs, and your bone marrow is an organ. So just like you can have kidney impairment or liver impairment, or you can require a ventilator to support you through that acute illness, your bone marrow is also impaired. And so we support your bone marrow when you're sick with transfusions. And if we were to do a bone marrow in somebody who is sick in the ICU, we might see dysplasia. Like we might see that the red blood cells or the white blood cells look a little bit funny because the bone marrow is stressed, so it doesn't really have its act together. What we shouldn't see is we shouldn't see that the chromosomes are altered, and we shouldn't see that there are gene mutations that are present. If those are there, then that signifies more of a primary bone marrow process. And if somebody has dysplasia because they're sick for other reasons, once they get better from that acute illness, their blood count should improve. And if we were to repeat the bone marrow, hopefully we wouldn't, but if we were to repeat the bone marrow, the dysplasia should resolve as well. So dysplasia is not always permanent.
So I'm pleased to introduce our second speaker, Dr. Lin Yang, who will give an overview of PNH, aplastic anemia, and new treatments for both. Dr. Yang is a hematologist, researcher, and clinical chair of the Chronic Lymphocytic Leukemia Program at Cancer Care Manitoba. Before medical school, she completed her PhD at the University of Toronto. The focus of her doctoral research was on cancer-driving genes in acute leukemia. Subsequently, she attended medical school at McMaster University before returning to the University of Manitoba to complete her internal medicine and hematology training. She joined Cancer Care Manitoba in 2018. She has a clinical practice in lymphoma and general hematology, including treatment of rare conditions such as PNH, aplastic anemia, and MDS. So thank you, Dr. Yang, for coming to speak to us today.
Yeah, it's still morning. Good morning, and thank you so much for spending your Saturday with us. It's always difficult to follow Dr. Houston. I have to say, next year I'm going to ask to go first. I do have the privilege of a variety of conditions that I follow in hematology, but today we're going to talk about some pretty rare ones. These are my disclosures. I work in a variety of hematological disorders, as you know. Okay, we're going to take it back to basics, and this will be redundant to what Dr. Houston would talk about, but redundancy is not always a bad thing, because it's the common theme, right? We're talking about disorders of the bone marrow. So this is a cartoon what a bone marrow will look like, and it's exactly what you would expect. It's inside the bones, particularly our long bones, pelvic bones, and it's very this spongy material, and there's like blood flow and vessels and stuff like that. And it's really just a factory that makes all of our blood cells that we measure in the blood. And the factory starts with something called a stem cell. So this is kind of like a very early on blood cell that then matures into the final product of either a red cell, a white cell, or a platelet. And what we're going to talk about are two rare conditions called PNH and AA, which are problems at the level of the bone marrow. So I'm going to split the talk with PNH first, and then we're going to talk about aplastic anemia as the second half. Okay, so this is a mouthful. This is why we say PNH, because the long term is paroxysmal nocturnal hemoglobinuria. And it was called this was discovered in the 1800s, but it was because people will wake up in the morning and their urine will look really dark, like rusty. And that's why it's called nocturnal, is because it's happened overnight. But now we know this is a myth. It happens all day. Like, it's not just at night. It's just that people thought in the morning the urine was more concentrated, so it looked more rusty. So that's how the name came about, but it's not only an evening problem. And the problem starts with the stem cell in the bone marrow. And I'll show you what that problem is and what it does consequently. It is caused by a single gene mutation, we now know. And this is not a gene that you inherited. It's just by chance, by luck, that you got this. And it is a rare condition, so we estimate that you get about one new case per million individuals per year. So it's pretty, relatively speaking, this is a very rare condition. So I'm going to make an attempt to describe how PNH comes about. I've made modifications from last time I'd done this, so I hope I don't lose folks. We'll test out the waters this year, because this is something rather complicated. It's not as straightforward. Okay, so we start with the stem cell. The stem cell, every day it's changing and mutations are happening, and most of the mutations we can get rid of because the body is programmed to get rid of bad cells, but once in a while a mutation sticks. And this mutation is called PIGA, not inherited, just somehow happened. And it does some unique things once you have this. So on the surface of a red cell, we're going to take a red cell as an example because this is the predominant problem in PNH. You have these surface markers. This is a normal red cell. It's beautifully, primed, and it's got all the markers it needs. But once you have this PIGA gene, you lose some of these markers. And once you lose this marker, the red cell no longer look the same as a normal red cell. So the body thinks then that is foreign. So then it triggers these really specialized proteins called complement. And what the complement does is come and destroy these red cells because it thinks now is foreign, even though they're your own red cells. So it ends up in a process called hemolysis. So the red cells and then just burst rather than going through a natural life cycle. And that's where majority of the problem comes from. Is you get this really surge or massive destruction burst of your red cells that are just abnormally broken, and it releases a whole bunch of things in the blood. And then it makes people's red cell count drop, so they become anemic, but in a very, very different way than MDS, right? This is a breakdown of red cell problem. And then you get symptoms from that. So what sorts of symptoms can we see in PNH? It's quite multi-systems. So there's a bit of a head-to-toe approach. So you can see from even the esophagus, the feeding tube, all the way down to head-to-toe approach. You can see every organ can almost get affected. The bigger ones that I want to draw your attention to is that there could be just non-specific or really vague abdominal pains, and that's because there's just not enough blood flow to the gut, so people get these pains, or they get spasms happening in the muscles of the feeding tube and in the stomach, so that's what causes pain. And that sometimes can lead folks to go to the emergency room in and out before someone clues in that this is actually PNH. Because when you do a scan, you don't see that spasm or the decreased blood flow. The scan of a belly will look normal. So it sometimes could take many visits before a doctor clues in that something else is going on. So it's somewhat frustrating. The other thing that it can form is blood clots. So although this is being a rare condition, it has a really high risk of developing clots systemically. So we're not only talking about blood clots in the veins of our system, like veins in the legs or in the lungs, but we can also talk about like heart attacks and strokes and odd blood clots in the belly. So we pay a lot of attention to that. And sometimes having a blood clot is how you present with PNH. You get this really odd blood clot, and then the doctors start looking into it and say, oh, lo and behold, it's actually PNH. So there's a variety of ways that we can clue in that something's happening. And sometimes the symptoms are just really not very, very vague. You know, you're really tired and you can't figure out why. You have difficulties concentrating at work. You can't keep up with your friends when you're doing activities, or with your kids with their activities. You're just really worn out, and you know, this kind of keeps happening, and then you can't find, you know, so what I'm trying to get at is you can present with one of these classic symptoms, or it could just be very vague as well. But anytime that you have these symptoms and you're not sure, you should go see your doctor. And typically when you do have these symptoms, they start off with a blood work, a typical panel of blood count, and that could show abnormalities, and then that ultimately leads to more blood testing, and then they clue in that something else is happening to explain this. And that often results in a referral to a hematologist like myself at Cancer Care. We see the case, and then we start doing our testing, and if there's enough clues there, either based on how you're presenting or your blood work, we will start thinking about PNH. And when you start thinking about PNH, it's actually really easy to test from a doctor's perspective, because PNH is one simple blood test. It's nothing invasive, one poke, one tube. It gets sent to the health science center, and it is a very simple assay, and it's a very good assay to say, do you have it or do you not? So anytime that a doctor starts thinking about PNH, you should just do the blood test. And when you get a positive test, it comes out as a percentage. So it doesn't say yes or no. It says, yes, this person has PNH, and this is how much of that PNH clone that's in the blood that we can detect. And that's essentially what we use to classify PNH. Because you can have what we call classical PNH. So those are where the clone size, how much PNH clone is in there, is about 50 or more. Then you have that kind of 10 to 50 range where it's subclinical. And then you have this even less common classification where PNH can be part of MDS or aplastic anemia. And the clone size is usually very small, less than 10%. And it matters a little bit what kind of classification you belong in, because those who present with the classic symptoms of PNH, like the blood clots and the abdominal pains and stuff, are usually the classical ones, because the clone size is big enough that it's causing problems. When you find PNH in the setting of MDS or aplastic anemia, it's usually just an incidental finding. They happen to do the bone marrow and then did some testing and then clued in, or something else is clued in, but they're usually just very silent. The PNH clone's not doing much. So once you get a diagnosis of PNH, you will be seen by a hematologist at Cancer Care. And this is where, as your medical team, we're looking at what size is the clone, is it affecting you, and if it is, how is it affecting you? And we're going to be for sure doing blood work to check all the things that we need to check. And more often than not, you will have a bone marrow biopsy. And the bone marrow biopsy is not to diagnose the PNH, because we already know you have it from the blood test. It's to make sure that we haven't missed MDS or aplastic anemia that can be associated with PNH. Because if you have that, then the treatment is very different than if you just have PNH without anything else. So it's really for that reason we would do the bone marrow biopsy. So that's how you would come to our attention at Cancer Care with PNH. I want to spend some time in treatment. And even since last year, since I've done this talk, I had to put in so many more slides in a very good way, because there's so much work being done in studying PNH, understanding PNH, always improving our therapies and improving our outcomes. So in a good way, my talk on treatment of PNH is probably twice as long this year as it is last year. Okay. So we're going to focus on those with classical PNH. So these are the folks who have, quote unquote, large enough clones of PNH that we think is causing them problems. We're not going to talk about in the context of MDS or aplastic anemia. Now, when you have a diagnosis of PNH, sometimes it was just picked up because of the blood work, but not everybody with PNH require treatment. Even if you have a large clone, sometimes you can live, it's really mild, it's not really affecting you, and you can just live just fine with that PNH clone. It's not doing anything for you. It may drop your counts just a tiny bit, like you may be breaking down your red cells just a tad bit, but not enough to affect your life function. So in those folks, we really don't need to treat. We would only focus treatment on those who we think the PNH is causing them some kind of problems. So in the province of Manitoba and in across Canada, there's a pretty standardized list of criteria that would make you eligible or we think symptomatic enough to warrant treatment for your PNH. So so you could be on the spectrum. Those are just being watched, seeing how you're doing, and those who present with classic symptoms and who now needs treatment. But when you do need treatment, you will have that discussion with your hematologist, and there are many options now that we can talk about. I will leave that to the next few slides. I want to say generally that the treatment is very good. We have many options, so even if the first treatment is not giving you the response that you're looking for, there are alternatives now. So we're ever so improving our outcomes, improving the quality of life. And if you do well on treatment, they have shown that life expectancy can be as good as someone who doesn't have PNH. So we've come a long way with how we've improved outcome in PNH. All the treatment that's available right now does not cure you of PNH. It does a good job turning around what we know is the problem with PNH. The only cure for PNH is a bone marrow transplant, right? Because it's a stem cell problem, so it happens in the bone marrow. So the only way to really get rid of it for good is to replace that bone marrow. As you heard from Dr. Houston's MDS talk, bone marrow transplantation is not something we take very lightly. It has toxicity, it has long-term consequences. And with how good we've come along with our therapies for PNH, bone marrow transplant is just not worth it anymore. So we rarely use this, if any at all. Before these novel therapies we were using or talking about transplant, but I rarely have that discussion with my patients at all. Okay, so what does treatment of classical PNH entail? So we talked about if you are meeting criteria, we think the PNH is affecting your function, your daily lives, is now time to start talking about treatment. We'll talk about kind of what that looks like. You always should have a discussion with your hematologist about blood thinners, because we know PNH put you at a higher risk for developing blood clot. So if you already had a blood clot and that was how you discovered you had PNH, you're likely to stay on the blood thinners. But if you have not had a blood clot and now you're diagnosed with PNH, we know that having that PNH does put you at risk for the clot. You should have a discussion with your hematologist about whether you should be put on a preventative blood thinner, at least until you get your PNH treated, get that clone down. Blood thinners not always for everyone because there are consequences of blood thinners as well, right? There's a risk of bleeding. So you always have to have that discussion with your hematologist about the risks and benefits. But that should happen with your hematologist. And if you're not on treatment for PNH, but you have some other symptoms, we can always talk about how to mitigate some of those symptoms as well. Okay. So we're going to go through a series of therapies that are available for PNH. We're going to start with a drug called eculizumab. It has been around since late 2000s. So now we've had over 15-year experience with it. It was the very first medication that was studied and proved in PNH. And we have learned so much from this. We've learned so much from it that we could improve on it even further with our experience with eculizumab. So I'm going to make another attempt to explain how eculizumab works. So it's a synthetic antibody. You get it intravenously. I'll talk a little bit about logistics of that. But what it really does is it's not going to change the stem cell and it's not going to change how the red cells look. Remember, none of these therapies are going to cure you of PNH. They're going to just alter how the PNH cell function, but not get rid of it. So that still happens. You still have the PEGA gene. It still will get rid of these important markers on the red cells and make the red cell look foreign. And it's still going to trigger these complements that's going to come in and destroy these odd-looking red cells. But what eculizumab does is it's actually an inhibitor to the complement. We know exactly which complement protein is responsible for this problem. And eculizumab is going to come and shut off that problematic complement that's destroying your red cells. And by doing so, your red cells are no longer destroyed. They're going to hang around in your blood longer. So that's how we prevent the problem of PNH. It's not really getting rid of the problem at the root, but shutting off what it's doing. So it's an antibody that stops complement, and it essentially just prevents the red cells from being broken down. So you have more, so the red cells, even though they're missing these important proteins on the surface, are no longer being destroyed, and you feel better. So we have learned also, very importantly, that with eculizumab, it not only improves your red blood cell count and it shuts off this problem of breaking down your red cells, it actually also, did that come up? Good. It actually also reduces your blood clotting risk substantially to the point where people perhaps who are on blood thinners after they get onto eculizumab could come off their blood thinners. So you could just take one medication instead of two. So there's been a lot of benefit. And we know that it substantially improved people's quality of lives because they're no longer dragging their feet and feeling tired and chronically breaking down their red cells and having that gut spasm problems, So all of that which should substantially improve with eculizumab. But it was very cumbersome for a long time, over 10 years. This is all we had. And people had to get it through the veins, through the IV treatment, every 2 weeks continuously. And sometimes people had to get it every 10 or 12 days if we felt 2 weeks was a bit of a too long of a stretch. So you're continuously committed to the treatment center or to an infusion clinic. And that's difficult to carry on your daily lives or take a vacation because, you won't get your treatment if you traveled outside of Manitoba. And with PNH, the average patient that gets diagnosed is around the age of 40. So it's a very young population. So you can think about what you were doing at age 40. You were busy looking after your kids, holding down a job, doing the errands, doing this and that. It's really very intrusive to your life too. And then every 2 weeks, remember, you have to go and get your IV treatment. And we also learned that infections were there was a risk of infections with these shutting off these complement proteins. So we also learned that you have to get mandatory vaccinations, which is a very good prevention for these infections, very effective. So every time you go on eculizumab, you have to get the vaccination prior to eculizumab, and then every 3 to 5 years thereafter to maintain the vaccination. So that has to happen along the way as well. So it was a very good drug, but it needed a lot of improvement. And we have, in the last, I would say, 2-ish years, have seen a bloom in this advancement in technology and medicine. So now in the province of Manitoba, we are shifting everyone away from eculizumab to revolutimab. For the most patients, there's still rare exceptions where you would still get eculizumab, but for the most part, everyone is shifting to revolutimab. And so you can tell by the name, the similarity of the name, they function very, very similarly. But they redesigned eculizumab into revolutimab so that it actually hangs out in your blood system for much longer, so you're not committed to that every 2-week treatment. Now you can go every 8. So for the first time in the patients in the clinic, they can actually take a vacation with their family, go to Disneyland for 2 weeks and not worry about it. And it's also been designed to improve how well it works, not only how long it works, but a little bit of how well it works. So the studies that were done were a number of years ago. As we were talking about clinical trials, they do the clinical trials, show improvement, Health Canada approves it, and then the province. So that still is a few-year process, but we finally have it available, and they showed that it did a very good job, maybe to some degree even a little bit better than eculizumab in improving your blood cell count, and it really gave back some quality of life. You still have to get IV treatment, but at least it's every 2 months now. The con is that you still are at risk for those infections, so you still have to be vaccinated on a regular basis, but it's the job of the hematologist and the medical team to keep track and make sure you're updated as time goes on, because in 3 years, people forget. And it is a continuous treatment, so there's no stop. As long as it's working and you're getting improvement and then you're tolerating the treatment, you just keep going. And now, finally, this year, and a bit more, we now have treatment even beyond eculizumab and revolutimab. And these drugs are designed to have even a broader coverage of these complement proteins. So it's hitting a few more complement proteins than the ones that eculizumab and revolutimab are hitting. And because it's going broader, they've also designed it to work in different ways, different pills versus injections. But bottom line is still continuous treatment because these are non-curative therapies. Pegcetacoplan was the first one that was approved in Canada and in Manitoba, where if you are on eculizumab or revolutimab and you're still not getting that maximum benefit that we hope you're getting, or you're not tolerating it for whatever reason, now we have access to pegcetacoplan. This is very different. It's not a manufactured antibody against the complement protein. It's an inhibitor. It's like a protein inhibitor. And it's much broader than just what revolutimab and eculizumab can cover. That's why it's used for folks who are already on an existing protein or just not getting that benefit. So you want to go broader to cover a little bit more of the complement proteins. So there's a very specific criteria that the province and Health Canada has outlined that says who would be eligible for this treatment. It's different in the sense that it's not given through the veins. It's self-taught injections underneath the skin, and usually we give it in the tummy because there's a little bit more fat there. So that's what we call subcutaneous. The patient support program for pegcetacoplan provides nursing support that would teach an individual or their caregivers on how to give this to themselves at home. And we would do this starting at twice a week. So the benefit is that it improves the red cells, and you could argue it improves the red cells better than ravulizumab or eculizumab because it's going broader, but it's only for folks who meet this criteria, who needs that broader coverage. It's giving you back a little bit more quality of life because you can self-administer at home. You're not committed to an infusion center or a cancer center, and you can take these products with you anywhere you travel worldwide. It comes in a little refrigerated packet, and you can just take it anywhere. So again, with the new inventions, new developments, we're seeing improved in quality of life. The con is you can get a local reaction with any kind of injections that you give locally in the tummy. You can get a little bit of redness, but that's very minor issues. We have not seen major issues or side effects with this treatment. And then now we have 3 more therapies that are potentially available or coming down the pipeline. So danicopan, iptacopan, you have to learn to pronounce these names, are now Health Canada approved, which means the studies are very good. Health Canada says, yes, this is something that we will approve. Province of Manitoba has not yet kind of taken it on, but they are available through what's called a compassion access program from the drug companies that makes them. So if you have somebody who you think could benefit from this, you can write to the drug company and they will supply it for free until the government of Manitoba negotiates and picks up the contract. So that's called the bridging or compassion access program. So that's really how it works, and that's a pretty standard thing that drug companies do until drugs are funded locally. So what are these drugs? So again, these are medications that are going broader, even higher than pegcetacoplan to cover a bigger range of complement proteins. So therefore, you're only eligible if, again, you're not responding as well as we expect with ravulizumab or eculizumab. So it's not that we start with these drugs, that we would think about these drugs if you're not responding to standard. And to give back quality of life, they are now pills you take. So no more injections. So you can take these pills. But the cumbersome part is there are some gut irritation side effects, which is ironic because if you're having nausea, you don't want to take your pills, but you got to take your pills. So there's a little bit of nuances there. But you also have to remember to take them pretty regularly. So danicopan is 3 times a day, but it has to be taken on top of your ravulizumab or eculizumab. So let's say you're on ravulizumab every 8 weeks with the IV, and then you take this on top 3 times a day. So it's quite cumbersome, in my opinion, to remember to do that. Again, you're in your 40s, you're chasing your kids at daycare and taking this to hockey and that one to piano, and you got to remember to take your meds in between all of that. Is very difficult. The drug companies will help you remember. They'll send you reminders, but you have to be the type that will remember to take medications, because if you don't, then again, you're not shutting down that complement and your cells will break down. Iptacopan, you can just take by mouth on its own. You don't need to take it with ravulizumab or eculizumab. It's twice a day. So I put that little blurb on the bottom that you have to be a good pill taker. If you know you're not going to be a good pill taker, then this may not be the treatment for you. So with these newer therapies, it's very important to have that discussion with your hematologist about, am I meeting the target with eculizumab, ravulizumab? Are we where we need to be? If we're not where we need to be, is there an alternative, and which alternative is best for me, looking at administration, side effects, efficacy and all that. And then coming down the pipeline, like really, really soon, is covilimab. It just got Health Canada approval, and they're just working on the compassion access program through the province, through the drug company. So they're just finalizing that, but I expect this very, very soon. So covilimab is studied in 2 forms, but in Canada is only approved for 1. It is a subcutaneous injection, so again, self-taught injection underneath the tummy in the skin, and it's only once a month. So again, trying to balance how it works, how well it works with quality of life. So now you can just do once a month injection and just stay at home and go on trips and take this drug with you wherever you go. And in Canada, it's for folks who, again, are not meeting the target with eculizumab or revolutimab. In the United States, it is used for that purpose, but also to start off with this instead of eculizumab or revolutimab. But that's not the Health Canada indication. In Health Canada is if you're not meeting your existing target. So very exciting time to be in PNH because you can see the evolution and the translation of what we know from the biology of disease into really meaningful and better therapies. And I expect this to continue to develop. I didn't have a boring slide of the drugs in testing, but in PNH, we have an equally long list as in MDS. Many, many targets, many, many drugs are in development, and I think there's going to be a big boom in the next couple of years looking at even better newer therapies. We're going to shift over to aplastic anemia. It is entirely different than PNH, but it is nonetheless a bone marrow failure problem. And sometimes there's a bit of overlap with MDS because how these folks present is really low blood counts. It is rare, so it's about 2 per 1,000,000 adults per year. And I'm going to go back to the theme of today, which is bone marrow problem, right? The aplastic anemia hits at the level of the stem cells and of the bone marrow. So you have problems making red cells, white cells, and platelets. And because you have problems making these cells, you start to feel them. It starts to impact you on how you function your daily life. So with low white cells, you could be at risk for infections. With the low red cells, you're more tired, you're dragging your feet, you can't go up a flight of stairs without getting winded and having to rest. And then if you have low platelets, you're at risk for bleeding. Infections with low blood counts can be quite serious, so I just want to put that statement in that if you did have very low infection fighting cells and you have a fever, you should get instruction from your hematologist as to what is the next step, and we treat that very seriously. Aplastic anemia is very, very different from MDS because aplastic anemia is a failure to produce the blood cells, whereas MDS is you were making the blood cells and then all of a sudden they don't look healthy. This is a production problem, this one. And we kind of divide it into 2 camps. One camp on the right is those that have it inherited, and there's a few genetic conditions that we know that put folks into a risk for aplastic anemia. So these typically come to medical attention when the folks are as kids. So I don't see them as much as in adults because when they present, they're often less than the age of 17. The other camp on the left side are some of the associations that we think could be leading to aplastic anemia. And it is an immune problem, so you can see a lot of these conditions could be immune background, right? So pregnancy is an immune condition. Lupus, if you know what that is an immune condition. Infections, certain medications. So it triggers some immune miswiring to then shut down the production of these blood cells in the bone marrow. And we look for these. We can tease out a lot of this by meeting you in the clinic and getting to know you. And but I have to say, there's quite a bit of cases where we actually just don't know. We look for these things, they're not there, so we just call this idiopathic or unknown, it just happened. Because there's so much overlap between MDS, aplastic anemia, the blood counts could all be low, you absolutely need a bone marrow to diagnose it and to differentiate it from other bone marrow failure problems like MDS. And I've shown you a figure, hopefully it's as striking to you as it is to me. On the right, you have what a normal bone marrow will look like under a microscope. This is what the pathologists are looking at. This is what we're collecting when we're doing those bone chips on the bone marrow biopsy. You can see it's filled with these kind of black dots, and those are healthy looking blood-making cells in the bone marrow. It's a factory, right? And then on the left, you have someone who would be considered aplastic. You see these white bubbles or white fillers that should have been blood cells, and they're not. They're not there. They're just super empty. And then the pathologist would tell us this is an aplastic marrow. You're not seeing dysplasia. You're not seeing that there are cells and they're ugly looking or abnormal looking. They're just not there. It's just very empty. And the pathologist will help you kind of gauge how severe, but the severity is not only based on the bone marrow, but your blood counts and as well as an integrated assessment. But it's kind of ranked by non-severe, severe, and very severe. And the non-severe ones, you can observe. You don't really have to do much because the counts are a bit mild and it's not really affecting you. But those who are severe or very severe can run into trouble because you're not able to support your blood supply, right? So those are the ones that we would seriously consider treatment. So we have come some ways with aplastic anemia treatment, although I think there's a lot of movement that needs to happen in this field. First and foremost, we would look for a cause and try to treat the underlying cause, right? Pregnancy, lupus, HIV, we know how to treat all of those. And hopefully by treating this and rewiring the immune system or deliver the baby, these counts will get better on its own. But if you can't find the cause, that's when the hematologist needs to have further discussions about what do we need to do to reset this bone marrow. But that process could take a while. You know, you come to medical attention because your blood counts are low. You have this bone marrow that takes a few weeks to get the results. And then, you know, you meet the hematologist and they try to figure this out. So this process will take time. It's not going to be an overnight thing. So until you guys figure out what is the cause and what's the evolution of that, most folks who are severe or very severe will require transfusion support until you can turn this thing around. So transfusion support would be blood or platelets depending on how low the counts are and how it's affecting you. And then obviously when there is an infection, you must treat it because we take that very seriously. And the treatment is very complex. If you don't have a reason and we think this is just idiopathic and now you need to turn around the bone marrow, it involves really a very coordinated team. And I'll tell you why. One is if you are quote unquote younger and you have a stem cell donor, we would try to get you a allogenic stem cell transplant, so someone else's bone marrow. So it's not your own, it has to be donated. But because this is a immune problem of the bone marrow, it's not like we can just take anybody's bone marrow. It has to be very selected and matched in a certain way that we know your body is not going to reject it. So that's a hard thing to do. It's less of a problem now because we've gotten better in our donor selection, but it's unique. So some folks will not be eligible either because they're older and not able to tolerate the transplant, or they just don't have a good donor. So then we shift over to the other side, which is immunotherapy. It's an immune problem, so we give immunotherapy. And the typical panel of immunotherapies we would give would be something called antibodies, again, to try to rewire the immune system, but this requires admission to hospital and monitoring. We'll try to give steroids. We'll try to give immune dysregulating or re-regulators, and we try to stimulate the bone marrow to make its own blood cells. And we'll use these all together in some combination. And the goal is with the combined treatment that you'll rewire, but it will take time for your bone marrow to respond and to then regenerate properly. So the whole point of this is it's going to be months and months of treatment. So we're looking at least 6+, if not a year or longer treatment. And you can imagine the side effects you may experience from being on these treatments for that long, so particularly prednisone steroids. There's long-term side effects. We're monitoring very closely, so you'll be doing lots of blood work to make sure that you're tolerating the treatments, your organs are functioning, but it is a long haul. So my take-home messages today is that these are rare but pretty serious bone marrow disorders. It takes a coordinated team to kind of figure out what is the cause, what do we need to do to reset this bone marrow. But I think there's a lot of promise. I think where we are in science and technology has really driven the translation to really meaningful therapies with good, better outcomes. So I thank you for your attention today.
Thank you very much. Any questions in the room?
I have a couple of questions, if that's okay.
Yeah.
My first one is, with the last new drug that you mentioned, I can't remember the exact name, is Empaveli included in the criteria for being approved for that?
No, you're talking about crovelimab, the subcutaneous one that's coming soon? No, as long as you're on a you know the terms, C5 inhibitor, eculizumab or revolizumab, and you're still anemic, that's the big thing, then you could go with crovelimab.
So
you don't have to be on pegcetacoplan to go on to, that's my understanding.
Okay, I guess. So
Oh.
I was on those,
Yes.
but then I had to go because those stopped working. Then I moved to pegcetacoplan. Does that because those didn't work, that would still be in the criteria?
Yes, because because there was exposure to, you were previously treated with eculizumab and revolizumab that then deemed inadequate. So then you already met criteria for an alternative complement inhibitor. Absolutely, yeah.
That's
Yeah.
good to know. And then my other question is, so if, like, with a PNH diagnosis and an aplastic anemia diagnosis, what is the approximate potential of developing, like, MDS and other things? Is the risks of that?
Maybe even Brett can help me with, Dr. Easton can help me with this answer, but I don't think there is, I don't think the chance, how do I say this? Because aplastic anemia and PNH are already bone marrow disorders that are acquired. It would be pretty rare, if any at all, that you would then develop a dysplastic problem. I cannot see any of the treatments for aplastic anemia and PNH putting you at risk for any of that. Okay. Would you agree? I don't know. What do you think? Like,
I would say possible but unlikely.
Okay.
That's, I guess,
Yeah.
good to know.
Like aplastic anemia, MDS are kind of mutually exclusive things ish. Yeah.
Okay. Yeah, I guess that's it then. Thank you.
Okay, thanks.
And we do have a question on the line, which is, when trying to reset the bone marrow, what percentage of people never get a true reset and have it for life? I'm assuming she means A.
Aplastic anemia, yeah. I don't know the number off top of my head because they're just so rare disorders, and we don't have an aplastic anemia registry where I can, we can look at our outcomes. But the goal of AA treatment, if you're doing immunosuppression, is not always to restore to 100%, is not to always get rid of it. As long as there's improvement and the numbers are adequate, that will be sufficient. Is that fair? And most people will get there.
Any other questions in the room? Oh, okay.
MDS.
Can you just wait? I'll just bring you the microphone so everyone can hear.
If you have MDS, is it possible to get PNH later?
Yes, not common at all. Remember this, how rare this condition is. So small percentage of MDS patients will have a tiny PNH clone, for example, at the time of diagnosis. But it will be inconsequential. That PNH clone is not doing much, it's very small, it's not causing any of these problems. You get your MDS treated, and then years down the line, that PNH clone, in the absence of a stem cell transplant, that PNH clone can expand. And then you'll get to a point where that PNH clone now becomes the dominant reason why you're anemic. Not a common scenario at all, because PNH is uncommon, is very, very rare, and then to have it in the setting of MDS is not common, right? But similarly with aplastic anemia, that could happen. You get aplastic anemia, that's maybe even a little bit more common than MDS with PNH. Aplastic anemia is a little bit more associated with PNH than MDS would be. But aplastic anemia, have a tiny PNH clone, you treat the aplastic anemia without a transplant, because if you do a transplant, you're cured. But if you just do immunosuppression with aplastic anemia, years down the line, that PNH clone can grow, and that could be the predominant issue.
For the PNH treatments, endolizumab and revoluzinab, you mentioned that you need to take vaccines for it. From my understanding, the treatments attack the complements, preventing them to attack your own blood cells. But does that also indict a vulnerability in that they would not be able to attack for actual foreign cells?
Very excellent question. So complement proteins are naturally part of our immune system. We have multiple layers of defense when we're being bombarded with pathogens, infections. There's a first, rapid layer, and then there's more sophisticated immune defense. Complement proteins are one of the first rapid response to pathogens in our body. So it does a lot of things, right? It's primarily for infection, but for PNH, it's also regulating a whole bunch of other things. So we know that we learned from folks who were born without complement proteins that they're much at risk for infections, and we know specifically which infections they're at risk for. So from those young kids who were born without complement, we've learned what infections complement fight. So when we put someone on revoluzinab or eculizumab or any of the other complement inhibitors, we know exactly which infections are at risk for. So yes, so when we shut down the complement with a revolutimab, we absolutely have to protect you because you're going to be at risk for those infections. So the one that's absolutely required is for meningitis, for revolutimab. So you get the Neisseria meningitis vaccine. Now there's 2. It used to be just 1, but in the last few years, we now know we have to protect you against with 2 vaccines for the meningitis. If you go broader, more coverage of the complement proteins, again, we know we have to broaden our our vaccination coverage. So you get meningococcal and pneumococcal vaccines. So this is all part of standard, and it's because we know what these complement proteins, how they protect you normally. So if we're shutting them down, we gotta do the vaccines to protect you. But we know exactly which pathogens we need to cover. And vaccines have essentially, it's not 100%, but 99.9% of infections are now eliminated with vaccines when you're on these complement inhibitors. Answer your question? Yeah.
Any other questions? I'll just see if we have any online.
How are we doing now, time?
Don't see any online, but I have one for you. I think many of us have heard about changes to healthcare funding in the United States, and I'm just wondering, how you see that impacting maybe access to medications for our patients or clinical trials.
Access to medications, I have not, in the PNH world, where's the most excitement right now, I have not seen an impact with the changes in the US government. Where there is challenges, I think, is clinical trials. Because PNH is such a rare condition, we, as in Canadians and Americans and a lot of Europeans, do collaborative clinical trials together, because that's, for a rare condition, you need the volume of patients to be able to study a new treatment effectively, right? You need hundreds of patients ideally. So we often will participate in trials with the US and with a lot of the European countries. Since the new administration in the US, participation in clinical trials has been impaired a little bit because there's a lot more red tape. What can I say about it? It is what it is, and we're trying our very best. And lobbying that we need to work this collaboratively, especially for rare diseases like PNH. Yeah, but it has a bit of an impact, yes.